Have a fantastic meeting. Another thanks to those of you who have been here before. I think there's no better testament to running a good educational meeting than to have people who come back and vote with their feet, if you will. A big thanks for those of you who've been to this meeting multiple times. With that, now we're going to go ahead and start off the session. This is the Rheumatology Year in Review, and myself and my friend and colleague, Dr. Jack Cush, are going to do a little tag team about things that we thought were important concepts in rheumatoid arthritis treatment that were new over the past year, or about which there's new information over the past year. There are disclosures for the CME event, and Jack will start us off. Jack?
Okay. So concerto is just trying to get okay, concerto. So concerto is an interesting study because it actually asks the question about what to do with methotrexate in patients in whom you're adding other therapy to. So this again is an early RA trial where patients who had actually I had you down doing this one.
Oh, okay.
I was gonna do musica.
Okay. So it's, as Jack says, a very important question. One, obviously, all our patients ask. And we know that I think most of us in our practices think that we use the biologics in people who have not had an ideal response on methotrexate. And then the patients, at least for me, and I think hopefully it rings true for other practitioners, the patients will say, well, do I need to be on the methotrexate? And it's very interesting because if you look at registries worldwide, it's very consistent that among patients who are taking biologics, 30 to 40% of them are taking them at monotherapy, whereas I think we would not think that. If you asked me and said, well, how many of your patients take biologics as monotherapy? I would say, well, 95%. And then when you go look at the charts, it's what it is, I think, pretty universally. It's 60, 70% are taking methotrexate combined, but the rest have stopped it because they don't have ideal tolerance of it, or they just don't like the idea of continuing it, or various reasons. So a question comes up, and for years we've sort of negotiated with the patients about, well, geez, we know that methotrexate plus TNF offers synergy. We know that the X-ray results are better, and we've seen this in quite a number of studies, that they're really synergistic and it's better to use them together. So the question becomes, how much methotrexate do you need? And this is one of two studies that I think begins to address this. This is Concerto, early rheumatoid arthritis. All the patients were treated with adalimumab, TNF inhibitor, standard dose, 40 milligrams every other week. Then they were randomized to different doses of methotrexate, 2.5 milligrams, 5 milligrams, 10 milligrams, or 20 milligrams weekly. And one of the things we'll come back to is you can always say, gosh, I wish they had studied 15. I wish they had studied 12 and a half or 7.5. But you can only, you plan the study in the best way, and I think that the data are very interesting. Bottom line, and I think if you look at the graphs, what seems to jump out is that the 20 and the 10 seem to do better than the 5 and the 2.5. And this was good pretty much across outcomes that were looked at. So you see the DAS28-CRP remission rate. If you look at the development of autoantibodies, which is in the second sub-bullet of the third bullet, everything seemed to say that methotrexate, that 10 milligrams a week might be sufficient to be used in combination with TNF inhibitor. Now, one of the things about this study, I love this study, and I mention this in the clinic with patients. When patients say, Doc, do I have to stay on the methotrexate? And they're on 20, I find myself saying, well, maybe we could get you down towards 10. But of course, this design really didn't address that because this is de novo starts. They're starting both medicines at the same time rather than starting methotrexate, adding the TNF inhibitor, and then tapering the methotrexate. But still, I think this is very useful information, and it's something I bring to the patients as I say, can you stay on a little bit of methotrexate?
Did you ever find out why they used the inconsequential doses of 2.5 and 5? Did you talk to the authors on that?
Well, I think it was, yeah, I mean, 2.5 is not something that we would use. I agree with you that I would have liked to see 7.5. I think they definitely wanted to have a separation. They wanted to have a dose, and what if you had done 7.5, 10, and 12, and they all, 7.5, 10, and 20, and they all look the same? It would have been harder, I think, to say that all those doses were equivalent. I think this is an issue, I think with study design, sometimes it's good to have a less effective dose because it gives you something as sort of an anchor to look at your responses.
So aside from the responses of LDAS, on top, the other measure of responsiveness here was drug levels and anti-drug antibody levels, as you showed there, and also polyglutamation levels, methotrexate. Clearly, again, showing distinction between the high dose 10 and 20 versus a low dose and a superior. But again, the surprising thing here is that 10 is not any better and not any less than 20 with regard to any of these measures. And all the early studies showing great responses with 7.5 and 10. We've all gotten up to 17 and 20 and 25, but are we really doing that much better, especially when we have the issues of variable absorption, we're giving it orally. So it is interesting. Now, the next slide actually has to do with the point you asked. What do you do once you're at a certain dose? And should you go up? Should you go down? Should you go off? And Musica is a trial that takes 300 inadequate responders to methotrexate who are taking on average over 15 milligrams a week, and then randomize them to receive open label adalimumab and blinded 7.5 or 20 milligrams a week. And it used the usual clinical outcome measures in non-inferiority design. And in orange, the outcome there is an ACR 70. In green, it's an ultrasound outcome looking at synovial vascularity by power Doppler. And in blue, you're looking at HAC-DI with an MCID of a less than 0.22 drop. And showing you there really is no difference between these two, and that's sort of surprising because, again, you would expect there would be a major difference between those two, especially there seems to be with regard to the doses. But again, these were in patients who were methotrexate inadequate responders. The study is a little bit reminds me of the Jesmer study, the Japanese study, which we covered a few years ago, which was in Japan, where the average dose of methotrexate is 7 or 8 milligrams. They took methotrexate incomplete responders and then put them on etanercept. But they either put them on etanercept monotherapy or they continued the methotrexate. And continuing the ineffective methotrexate made a big difference with regard to both clinical outcomes and also with regard to radiographic outcomes. This study sort of mirrors that. You still need some, but you may not need that much.
Yeah, 7.5 may be enough. I really like this. Gerke Kelly presented this at ACR. I really like this because it answers another hypothetical question that comes up with this data that you didn't see in Concerto, and that is there smoldering inflammation that you're missing by our outcome measures, which are joint counts and DAS28 or CDI or whatever, that maybe you're having smoldering inflammation that might get damaged. So having the ultrasound evaluation of this answers that, I think, perhaps as best as can be answered, and says that you can perhaps do this, certainly for some patients. Of course, it's group data. Individual people can always have different responses, but I think this does say you can maybe get down to a dose of 7.5 milligrams.
So smoldering inflammation, I mean, it's really like a kind of conspiracy theorist here. There's always something going on.
There's always something going on in the joint.
All right, so this study actually looks at that. This is patients who are CCP or ACPA positive who have non-specific musculoskeletal symptoms. This is from the Leeds group. Over 122 patients, they found 22 actually had some swelling in their joints, so they excluded those. So these are people who have no clinical synovitis. They just have, oys and ouches and that kind of stuff. And they followed them for a year. And you can see the drop-off level in developing actual synovitis was about 47 out of the 100 occurred over the next a year. I think the number was about half of them occurred in less than 6 months, and 22 in less than 6 months, 33 or something like that after 6 months to 12 months. And the only predictor of those who are going to progress was early morning stiffness. This cracks me up because, again, we as rheumatologists make a lot out of morning stiffness as being a big important factor, and it's the most useless factor in practice if you really look at it discriminately. I mean, every fibromyalgia patient's all over the map on this, and these are the people who are going to present with some abnormal serology, early morning stiffness, and they don't have any swelling. Now, they did find that if you look at other things like power Doppler, They did MRIs in hands in this subset and showed that if there was flexor tenosynovitis, that you were, again, 7 times more likely to actually have progression to synovitis, a positive shared epitope and being double positive, and a higher titer of ACPA, again, would predict the progression. But we see these patients. These are patients, again, who have positive serology, and the question is, what do you do with them? Do you just follow them and wait for for bad things to happen and then treat them? Should you be treating them ahead of is this preclinical disease? If you treat all of them, you're going to overtreat half of them.
Yeah, and just released, I think in the last edition of Annals of Rheumatic Disease was the 5-year follow-up from the methotrexate study in undifferentiated rheumatoid arthritis. I think it was called PROMPT. And they took patients who were not exactly like this. These patients had synovitis but didn't meet criteria for rheumatoid arthritis, treated them with methotrexate, and remember, at a year they did much better, but by 5 years it didn't seem like there was much difference because, as you say, there's such a mix of people who really have RA and really don't have RA. So I don't think we need to treat them, but I found this fascinating. This was presented at EULAR, and I think you're right. You see these patients and you're all set to say, get out of here, don't come back, and then you have the ACPA of 250. And what do you do with that? I think we're not doing shared epitope, but and early morning stiffness, I collect that as part of my entry form with the hack and the pain and the global and the homunculus showing where you're hurt. And you're right, every fibro patient puts an X on every single joint and then areas between the joints and then over the whole body, and their morning stiffness is 24 hours. But morning, I think this says that, it's maybe it's not as useless. It used to be a tried and true part of how we evaluated people with inflammatory disease. So, but maybe there is some use for that.
I think, again, this speaks to the definition of remission. Also, we're all happy with clinical remission, but we know that clinical remission isn't true remission. Some of those people still have active disease. Yeah. Some of them may progress, but still is a good thing to find a measure that shows remission without getting too much into it, like with MR and ultrasound. But now, it says maybe you really need to meet that hurdle too if you really want to be in remission.
All right, so the next study
is this a sci-fi movie, Planetra?
Yeah, and actually the robot was CTP13 in that movie. No, this is a biosimilar, and this is a super hot area, and this is just something that was presented at EULAR and ACR and published, as you see the first reference. And this is such an important topic that we have a update on this very important topic by Dr. Vibeke Strand coming up later in the meeting. And actually also, as it turns out, one of the points that I want to bring up with this, when we talk about biosimilars, it sounds sort of hypothetical, like biosimilars, we're going to have them, but it's not. And actually on the faculty this year, we have Dr. Glenn Haugeberg from Norway, who actually has treated a patient with the biosimilar because it's in Norway. It's in the Czech Republic. When the patent expires in the summer of 2014, it's going to be all over the European Union. So this is a very important discussion, but it's not just a hypothetical discussion. So in fact, I told Glenn I'm going to put him on the spot and say, because Norway, it's interesting. It's a socialized system, but they have pay incentives that the government tries to work out with pharma. So how the biosimilars come is going to be sort of very interesting. I don't want to steal Vibeke's thunder, and she'll give us a very elegant lecture and a thorough lecture on this topic, but this is biosimilar infliximab. It's CTP13. I think it's being marketed as Remsima. At least in some of the countries, it's approved in Korea and Japan. It's now approved in Norway, and I think it's approved in the Czech Republic. It got a favorable opinion from the EMA last summer. And what that means is that an important aspect of that is that the only studies that they have for this are a phase 1 study in ankylosing spondylitis and a phase 3 study in rheumatoid arthritis, which is the Planet RA study. The other one is a Planet AS study. But the EMA opinion was that they get the whole package that infliximab has. So they get psoriasis, psoriatic arthritis, ulcerative colitis, Crohn's disease. They get the whole package. And it's interesting, I talked to the GI people in our group, and they seemed unaware of this. And they were very angry. They said, no, you can't have something approved if they've never had studies in Crohn's disease. That's crazy. And I think we feel that way in our gut, but how do you object to that? And I think this biosimilar was shown to be biosimilar. Here you see the clinical data. The investigators say that they're so identical that the antibodies to the drug are actually cross-reactive. So anti-infliximab antibodies bind CTP13, which you would expect because most antibodies are anti-idiotypic, so they bind the binding region, which is very similar. The other important part about this, just make one final point, is that what you see is that they switched. So they took people who were started on infliximab, and then they switched them to CTP13. And this is very tricky, very unexplored area, because the holy grail of this is going to be interchangeability, which means that you write a prescription, you can't say which the patient's going to get, because if it's interchangeable, the pharmacist can give whatever. And so it's a big, big issue. We'll hear a lot more about this in Vibke's talk, and we'll get Glenn to comment on how things are at least beginning to shake out in Norway.
But isn't this sort of like the punk rock? It's a hot issue.
Fad.
Yeah, because and you got to go there because of the money. But there's so many. First off, we're not going to see this in the United States until what 2017 and beyond.
We'll ask Vibke. I mean, because
and the second thing is that this is like, you know, I want Frosted Flakes, but my parents are buying frosty corn puffs
from Safeway,
from Larry the Lion,
from
instead
Costco.
of Tony the Tiger, and you know you got ripped off by your parents, and rheumatologists are not going to want to use this stuff for fear of safety, and they don't want to go there, and they know that someone's ripping them off, and they're taking away my Cocoa Puffs, and again, they're doomed to fail right from the start.
But I think you're right. There's the FDA has been sort of going slower, but if this is in Europe, and if it's in Canada, and if it's in Mexico, I think the political pressures to bring it to the U.S. are going to be very large. And so definitely an important area.
And the fact that every company is now in this business should make me worry as well. So.
Yes. A lot of stuff on pregnancy. Jack?
So,
a couple of abstracts here, a couple of important bits of information.
So everybody's aware that RA might be okay to get pregnant when you have RA. That the old adage was 80% of patients go into remission. That's actually, of course, not true. At best, it's maybe 20. About 50% of patients, 60% do well. Maybe 20, 30% get worse during pregnancy. So we know that association exists. This is a study from Mika Haas's group and whatnot. They have a cohort that's being followed prospectively, 245 RA patients, and they looked at the issue of infertility.
Is Whatnot a city in the Netherlands? Is it Whatnot? Is that by Amsterdam, Whatnot?
Whatnot, yes.
Yeah, okay.
Right. So this is the PARA study. Again, their measure of infertility is time to pregnancy. And if you can get TTP, and if you can get pregnant within 12 months, then you're fertile. If you're not pregnant within 12 months, you're subfertile. These are women who declare that they want to get pregnant. And the interesting thing about this study is that they looked at the influence of RA activity on the ability to conceive and become pregnant. And the graph on the right shows you the light blue line on top are the ones who had the most degree of activity. DAS scores greater than 5.1. They were the most infertile of the group. And the ones who did the best were the ones with a DAS in remission of less than 2.6. Other factors were older age, being nulliparous, prednisone and nonsteroidal use being markers for disease activity. And what Artie and I showed in an analysis of the corona subset was patients who got pregnant did so almost in a natural way. They got down to very low disease activity on very few drugs, and they went ahead with their pregnancy. This shows you that you're likely to get there if you're very well controlled and have on no drugs and whatnot. But the patients who are the most active are the ones who are having the hardest time getting pregnant. Again, not many studies have been able to show the influence of RA activity on what happens in a pregnancy.
And doesn't this fit with a lot of the anecdotal experience in the infertility, that inflammation can be an important cause of infertility, and that there are even clinics that were treating people with TNF inhibitors who didn't have any immune disease just to decrease systemic inflammation to allow the women to get pregnant. And this would say, I think, which maybe our experience in the clinic mirrors, that patients with severe active disease can't get pregnant.
Yeah. So this is Megan Klaus's. Do you want to do this or want me to do this?
No, you can do it.
Okay, so Megan Klaus looked at her 31 pregnancies among her RA patients. And again, it's a small cohort, but it's somewhat interesting in that a third of them were on TNF inhibitors, half were on prednisone. And when they looked at what happened to these individuals as far as their outcomes, again, they looked at the adverse outcomes being preterm delivery and preeclampsia. And that's shown over here. But you can see that the blue group, the ones on prednisone, they start out with more activity. They get better during the pregnancy, But again, of these, 54% had an abnormal outcome of either, again, preterm delivery or preeclampsia. Those who are on TNF inhibitors actually started out active, went into a remission zone basically, and seemed to do well with less abnormal outcomes, 14%. But the ones who were on no drugs started out with very little activity, continued on with very little activity, and they had no adverse outcomes. So again, it is disease activity that sort of portends what's going to happen with the pregnancy, and maybe even in other studies to be shown what happens after pregnancy.
And you'd, very small numbers, but you would say the TNF inhibitor looked better, looked certainly better than the steroid outcome, which gets to the other important question: are these medicines safe in women who are pregnant or wanting to become pregnant?
So the ACR just had a reproductive health summit where we identified through the Drug Safety Committee 2 years ago that pregnancy issues were the one issue that was highest on the list for a need for information, need for better information about how to manage patients and whatnot. And we sort of are starting to review this stuff and come out with what we know, what we don't know. And information about drugs is sorely lacking. And I think that this is the best way we're going to get information. This is actually analysis done by the maker of certolizumab and their collective experience, mostly with Crohn's patients, 309 pregnancies, but also a third or more with rheumatoid arthritis. And when they look at what happened with maternal exposure, 190 of them, they excluded the unknowns. I guess those are alien exposures, we're not sure. But when the father was exposed, actually the offspring of the father's exposure actually had the same pattern as the maternal exposure. And you can see live births almost 70%. Miscarriages, almost 20%, and elective terminations, 12%, with 4 or 3% congenital anomalies, and they're shown on the bottom of vesicular-ureteral reflux, Hirschsprung's and clubfoot, malformations of the aortic arch and its vessels, and a unilateral hydronephrosis. Again, that 3% number is within the range of what's expected in the normal population. So again, this is some data that suggests that there may be a role for patients to receive this. As you know, as you may not know, I guess that in Crohn's disease, it's much more common to continue these drugs than it is in rheumatoid arthritis, where the majority of patients who are on either a thiopurine or on a TNF inhibitor will stay on that drug throughout the pregnancy. Certolizumab has certain advantages by not permitting a placental transfer of the drug, and that may be an advantage to both the mother and also for the offspring. So this is encouraging. Our surveys, my surveys of rheumatologists say about 20% have no problem getting pregnant on these drugs or staying with these drugs throughout pregnancy. The remainder of the rheumatology community needs more information. This sort of thing I think is helpful.
Yeah, we'll never get controlled studies, of course, in pregnant women, but the abundance of data seems to be going toward that. And as you said, it was interesting at the Reproductive Health Summit, we had dermatologists, rheumatologists, gastroenterologists as the treating physician, and also maternal fetal health and patient groups. And the gastroenterologists, by far, the most aggressive. Their point is, you got to treat the Crohn's disease. If Crohn's disease becomes active, it's bad for the mom. If it's bad for the mom, it's bad for the fetus. Dermatologists, perhaps the most cautious, because they would say, well, if it's a psoriasis, we have light, we have topicals, can we do that? And the rheumatologist sort of in the middle, and I think we're probably heterogeneous. And do we go more like the GI and say, you know what, it's most important to get the disease under control, and certainly an important discussion that we have with our patients. So next, I wanted to cover a little bit about personalized medicine and what developments there have been. Some interesting things on that. So the personalized medicine, it's the parade of omics. You know, you all heard about genomics. So before the human genome was sequenced, it was going to cure everything. You were going to go to your doctor, swab your cheek, get your DNA, and get your pill at the way out. Well, of course, that hasn't borne out because there's really very minimal associations with genomics and important outcomes. Then the next was proteomics, the expression, because your genes are one thing, but it's really how expressed they are. Now there are a whole variety of others: glycomics, immunomics, kinomics, metabolomics, and now epigenomics. And leading into the next topic, we're going to talk about the microbiome, which may be related to that. It's interesting that I think some of us who do clinical research and talk to those who do genetic research, we call them gene jockeys, and they call us morons, because if we only sequenced enough DNA, we could figure out who needed what treatment. But I think they're starting to come around now. And here, this was a meta-analysis of meta-analyses of GWAS, genome-wide association studies, looking at a variety of SNPs, single nucleotide polymorphisms. And the interesting part about this is I think they're starting to come around with a concept that we'll talk about again in spondyloarthropathy and psoriatic arthritis, and that is we're learning from the treatments backwards. So we're learning, as we'll see, that IL-6 inhibition doesn't help ankylosing spondylitis. IL-17 inhibition is great for the skin, doesn't do so much for rheumatoid arthritis, makes Crohn's disease worse. We're going backwards, and this was an exercise in this. And this is important when we look at genetics. The data is the rate of concordance in identical twins, completely genetically identical, 15%. So there's some genetic component to it, but it's not the whole answer. But maybe this is sort of the answer. Going backwards from what treatments they've had, maybe we can then learn more and do it in a rational way, as I said, going backwards. A hot topic is epigenetics. So what is epigenetics? And I got to say, I read this, and then like 3 minutes later, I kind of forget it, and then I have to read it again. It wasn't something we talked about, when many of us were in school. So these are heritable alterations that can regulate patterns of gene expression but don't change the DNA sequence. You say, well, how does that happen? Well, there are things that, remember, you have your DNA, but whether it's expressed or not depends on its configuration, whether it's ready to be activated by transcription factors. And this is a super hot topic because, first of all, it's heritable. It's not genetic, but it can explain perhaps the influence of environment on some of our diseases. Things and here you see some things. So DNA methylation, whether or not transcription factors are methylated affects how easily they can be transcribed into proteins. And this can be affected by things like diet, which sounds sort of California-ish, but is actually, there's something to this. Some of this is easy to understand if you have diets that are super high in folate. We know that folate is important for single methyl metabolism that's important for DNA synthesis, but also maybe the microbiome influences this process, and it's been shown. MicroRNAs can be important in these too. They're heritable patterns that can influence things in subsequent generations. They're not irreversible, so they can be changed, but they may relate to how the environment passes things along. And then modification of histone proteins. And this is something I came across relatively recently, that PADI4, the enzyme that makes citrulline out of arginine, is actually important for chromatin decondensation. So normally, your pluripotent cells, the chromatin is open. The cell can do anything it wants to do. That happens sometimes with inflammation. Happens in neutrophils, and inflammation also happens in pluripotent cells. So PADI4 and citrullination is a very tightly regulated process. The oncologists are very interested in this because once you make a cell pluripotent, all bets are off about what might happen with that. So epigenetics seems to be a hot topic, and I think relates to something that Jack's going to take us through, the microbiome.
So obviously the microbiome has become another new hot topic, an extension of what Artie just reviewed. Interesting facts that, if you reduce your DNA composition, you're only 10% human, 90% microbial, which is a little disturbing to patients when you tell them that.
So we're basically like the Starship Enterprise for bacteria. We just carry them around.
Pretty much.
Yeah.
We're just the host. And and of course this microbiome, these microbial communities are important in multiple functions, as listed on the left: digestion, immune function, toxin degradation, and pathogen defense. On the right is just a cartoon, basically in a color-coded way, showing you the differences in microbial makeup. If one looks at on the left and going down, hair, nostril, skin, and vaginal microbiome. On top right going down, oral cavity, the esophagus, H. pylori positive and H. pylori negative, H. pylori positive, H. pylori negative microbes in the stomach, and then down here, colon. Obviously, all very different. Obviously, very much affected by disease and by a predominance of one bug over another. So there are a number of microbes now that have been implicated in being altered either within the mouth or within the gut, within the lung, and possibly even on the skin, and that becoming important in disease expression. The issue is that we know of patients with rheumatoid arthritis and lupus who have serologies that exist long before they ever develop disease, and you follow them over time, and they ultimately, a cohort will ultimately become a clinically manifest disease. The question is, what are the triggers along the way, and are these alterations part of those triggers that could be involved in epigenetics as well, and other factors that we don't yet know? It's interesting, I think, to look at. So if you go forward, sorry, you have that. So here's one experiment that actually comes from Colorado, which looked at 13 CCP positive but patients who have no clinical disease, and compared them to 9 healthy controls. And they did induce sputum samples and looked at the microbiome of the sputum that was produced, and showed a clear-cut difference between those who were CCP positive versus those that weren't. More Haemophilus and Streptococcus, lower Prevotella. And then when they looked at some imaging, I assume this is gallium imaging, 9 out of 13 of the CCP positive had subclinical inflammatory airway disease that wasn't clinically manifest but was evident on lung imaging. So here's a possible link between changes in the microbiome and what may develop into disease later on. The next is a study that actually looks at probiotics. Now, probiotics obviously are very California, but we're using them a lot in our IBS patients. They're being used a lot in GI for the control of inflammatory bowel disease. This is a double-blind, randomized trial of 46 patients who either got lactobacillus or in the probiotic, or some inert maltodextrose or something like that as a placebo, and looked at them 8 weeks later. If you look at the scale on the left, which looks at DAS scores, the numbers are pretty low. These people don't have much activity. These are 2.4, but they get better compared to the ones that are on the probiotic versus the placebo. There's a clear-cut difference between the before and after, suggesting that there could be a benefit here if one were to influence the gut microbiome in the form of probiotic therapy. And then lastly, this is a conglomeration of slides of all of them, but I threw in Steve Abramson's presentation at the Biologics Conference at the Cleveland Clinic, where he reviewed their experience with about 40-something patients looking at the gut microbiome and stool samples, and showed an abundance of Prevotella, and then showed this correlation between Prevotella and TMAO, a substance that shows to be has a high predictive value. People who have high TMAO values have higher rates of cardiovascular events, suggesting again that the microbiome may be influencing activity, may be influencing subsequent events like cardiovascular outcomes. So I think there's still a hot area. I don't think there's any clarity here, but it's interesting to look at this and look at the gut microbiome or lung microbiome in terms of what we do know about the health, with the gingiva being involved in both the onset or risk of RA and also the severity of RA. And also, same can be said for the lung, and now we could probably throw the gut and maybe the skin in. And these may be yet another modifiable factor that one can use to better control the disease in the future.
Yeah, I think there's definitely something here. I just don't, I hope it's soon that we can make something sensible for our patients. But you think of what we've had in the past about antibiotics, which of course dramatically change your gut microbiome, diets. And I get a lot of people who go gluten-free and they swear their arthritis is better, and by all testing, they don't have gluten sensitivity, they don't have celiac disease, but they've also lost 15 pounds. And all these things that can change the gut, I think 20 years from now is going to be a definite answer on this, and maybe they can do something about it based on that. Certainly a very interesting and exciting area. Look, we're talking about personalized medicine, and one area we still want is biomarkers. So this is something, this is an abstract that was shown at EULAR. Looked at the ADACTA study. ADACTA was a head-to-head study. Monotherapy TNF inhibitor adalimumab versus IL-6 inhibitor tocilizumab. And the question is, that was addressed on here, can you tell which patients did better with which therapy? Because that's what we want to know. Is there something that we could say that you could say, well, you know what, you have a better chance of having this treatment. And we don't have anything right now. It's just say, let's try this. And I think our choices are made on financial reasons and adverse event considerations. But this, what was done here is they looked at simple serum markers, soluble ICAM and CXCL13, and used those as an indicator because it has a relatively good, strong correlation with what you would see in synovial histopathology. That is that the soluble ICAM fits more with the myeloid pattern on synovial biopsies, the CXCL13 more with the lymphoid. And it's interesting, the part that really struck me was that it's really the combination. And a lot of time, there's a lot of people for whom it doesn't make any sense, but if you have, as you see on the left-hand side with the tocilizumab, if you have a high CXCL13 and a low ICAM, that gives you a better chance for response, and it seems to be the opposite for adalimumab. So for biomarkers, I think philosophically we've always been looking for the home run. So give me that one test, give me a level of this that says I should get a TNF inhibitor versus something else, but why should it be that easy? The immune system is certainly not that easy. I think we need to think in more complex ways, and maybe we will find an answer that helps us be able to say this patient is the best for this kind of treatment.
But the problem, of course, is that we still have these horrible decisions to make in patients who have cycled through the big 3 TNF inhibitors, then you're left with 6 other biologics to use, and you still don't know what to do.
Yeah.
And we have enough of those patients around, and I don't know why we don't have more data like that, or that data isn't being put into play more, because otherwise it's just a crapshoot, and it's actually based on a deselection process. You choose remaining drugs based on where you don't want to go, based on the patient's dislikes, profiles, comorbidities, or finances, and that becomes a deselection choice rather than a positive selection choice. This is the triple DMARD. It is the sort of the Achilles heel of rheumatology, I think, and I am in favor of it in some patients. The question is in who, and Jim O'Dell and his colleagues have worked hard to convince us through the original studies and then the TIER study and now this RACAT study, R-A-C-A-T, which is a combination of the RAIN network and the VA and a bunch of Canadians who basically people didn't know better to get involved in the trial. I was involved. Only kidding. But you know, it's an interesting study because it continues to show the same principle. This is different than TIER. TIER were patients who had brand new disease, early disease, and they had a run-in of methotrexate, and then those who didn't respond were then randomized to the initial therapy or the step-up therapy. Here you have patients who are methotrexate incomplete responders who are randomized to receive the added etanercept on top of methotrexate or triple DMARD going forward, and you can see based on the graphs that are shown here that the two groups do equally well, and the patients who didn't respond over here were crossed over to receive the opposite therapy, and there was an equal response in those as well. What wasn't seen was a difference in X-ray outcomes between these groups. There was an early benefit for the etanercept-treated group in the first 6 months that really didn't pan out over time. But for the most part, the real difference here was in the cost. That there was a tremendous cost savings, obviously, in triple DMARD versus it. Again, there was lots of issues about this trial that those who don't want to believe in the data can point to. One of which was this very slow recruitment in enrolling the study. The study was not fully enrolled and was stopped at some point and analyzed as is. So again, I don't know. I haven't seen that TIER or RACAT, although they've been great publications, they're not getting the respect that they're due because they've been posters at the ACR and there's still not very many people using triple DMARD therapy.
Yeah, I think this abstract, the paper was fascinating. We did it, and I'm sure many people have done it if they have local journal clubs. And it was published in the New England Journal. But as you rightly say, there are so many issues with it. Not only did they recruit slowly, but they changed their primary endpoint midway, which it just doesn't feel right. Their analyses were done just after 6 months. They only did the 3 analyses, so it discounts a type of therapy that might work faster, and whether or not that's important to someone. And also, some of the X-rays are completers. So the patients who stayed in did well, and people who do well, and anybody who wasn't doing well got the other therapy. So in a way, you're almost certainly going to obviate any differences by the design. So it's interesting. I think you hit it on the head. We see this data, and it hasn't made everybody immediately stop, although obviously it's had an effect on some payers in some parts of the world, which of course we don't like.
Yeah, and I think rheumatologists' belief or disbelief in triple DMARD therapy is going to be tested because the payers are going to make them go there whether you want to or not. And then you'll find out with, it's great to talk about, anakinra and how crappy the drug is when you've never used it. But when you're forced to use it, you'll figure out whether anakinra, or in this case, triple DMARD therapy, is as good as the published results.
Okay, and then maybe we'll just end with this topic. The time is getting toward the end. So TNF levels and drug levels. This is interesting because I think most of us grew up with the idea that the anti-drug antibody tests they weren't that reliable. Certainly 15, 20 years ago they weren't. But now there are more reliable tests. And also measuring both the drug level is easier and it's better and more reproducible, as are antibodies to the treated products. So this is interesting. This is a study just done by an investigator in Spain. Took their patients stable on a single TNF inhibitor, all on combination therapy, looked at anti-drug antibodies, and also looked at the serum concentration. And what they would suggest is, you see here, is that if you have a low level of the TNF inhibitor, of adalimumab, so across the top here, those with a low level didn't do as well. Higher DAS score more anti-drug antibodies. Above this level, roughly 3 micrograms per liter, they did better and didn't develop anti-drug antibodies. And some people would go further with this and say, well, maybe these people are on too much. Maybe these are the people who you taper, or go to every 3 weeks, or every 4 weeks, or do something else, thinking of cost. So are these going to be used? Our colleagues in GI use these a lot. They, of course, a difference is that Crohn's disease can be associated with a protein-losing gastropathy, which can affect drug levels, but they're big believers in these, and I think rheumatologists had tended to discount it, but might they be able to help us make some decisions? And this is from Europe, where they have an algorithm which maybe makes sense. So if you have a patient, they're on a TNF inhibitor, they're not doing as well, or they're no longer doing as well, measure the drug level. If the drug level is low and they don't have antibodies, maybe they need a higher dose. If the drug level is low and they have antibodies, go to a different TNF inhibitor. If the drug level is good and they're antibody negative, maybe TNF blockade is not perfect for them, go to another mechanism of action. So it's not proven, but I think it's sort of sensible. And I come from the background of sort of being very suspicious of these tests. What do you think, Jack?
Well, it's hard to not pay attention to the data. I agree. I've also not been, these are very popular, I think, in GI, and what bothers me is adalimumab is the sole target of this. I mean, you could go after other monoclonal antibodies as well. This seems to be less of an issue with the receptor. But I think that you can avoid this by using, and the testing, by using very high doses of the monoclonal antibody therapy and coupling it with methotrexate enough to suppress anti-drug antibodies, or to look at this and, as you say, use the algorithm to make decisions on where to go with your DMARD therapy or the biologic that you may use. I think that this sort of strategy needs to be tested in a good clinical trial to know whether it has true utility. But until then, I think there are more people who are going down this path.
Okay, well, we had more slides, but we want to open it up now for questions and discussion. Maybe we could have the lights up a little bit if we could. The front right, Vibeke?
Yeah, well, I just wanted to comment about this and also about the Musica and Concerto studies. So, I mean, I think that this is a reasonable point, but in fact, we follow people clinically.
Yes.
And if we just follow them clinically most of the time, I don't think we need to do all this. There's an issue about how to do the antibody assays and the interference from drug levels on the antibody assay and how good the assay actually is. And of course, the Wolbank group in the Netherlands has picked adalimumab as the big topic for the last several years of work. So it's interesting, but I would suspect most of the time we don't need to do it. What's important about Concerto is that was where we were starting both drugs at the same time. Your polyglutamate levels were not even stable yet. They take 3 and 6 months to be stable. And so you're actually looking at efficacy based on the methotrexate dose as well as the adalimumab dose. And therefore also the effects on the immunogenicity, antibodies, and drug levels may not be the same. What's interesting about Musica is everybody'd been on methotrexate, they'd already failed it, their polyglutamate levels were now quite stable, and now you don't see a big difference between taking them down from their dose of 15 to 25 or you leave them on their regular dose that they've already been on. So I think what it really says to us is actually you can use methotrexate or any of the other DMARDs we use, like MMF or azathioprine, as background therapy, leflunomide too, for immunogenicity. And as long as people have been on it with at the same time as the first dose of the biologic, you get a beneficial effect. And you don't need high doses. Now, I don't know whether 2.5 is too low, but 5 seem to be fine.
Yeah. All right. Yeah, and it gets the issue of study design, because to do a study, you have to be very controlled, but sometimes that doesn't allow all the good clinical questions that you want to ask.
But Vivica, 5 was not enough. It needs to be 10, or in the original Maney study, it was 7.5.
It was the lowest, right?
Was able to suppress HACA antibodies.
The back left microphone? Yes.
Yeah, I have a question about triple therapy versus methotrexate plus anti-TNFs. Have they looked at the rate of like side effects of the medications between the two groups and the dropout rates? Because in my experience, patients on triple therapy have much more trouble than the combination biologic plus methotrexate.
Yeah, that's a great point. They do, and in what they've reported, the side effects are actually relatively similar, but I think your point is a good one and maybe speaks to the issue that people who are in a study, they're not your free-range patients. They're the highly selective, compliant patients who are going to tough it out, and those of us in the clinic, I mean, that's a very practical issue people have raised with this triple therapy regimen is, look how many pills you're taking in a single day. And people don't like that. So I think that is a point. But from what they've written, the side effect profiles were not so dissimilar. Roy?
Yeah, so very quickly on Concerto and Musica, what was really important in those two studies was the side effect profile of methotrexate. It really wasn't difference between 2.5 milligrams and 20 milligrams. And that's something that none of us ever really expected. So starting at a low dose because you're worried about side effects probably doesn't make sense. The second is, at least in Concerto, the primary was a dose response curve. It really didn't look at 20 versus 10. And it's a mistake to say that you can start at 10 and that all you need is 10. That really wasn't looked at.
Right. Well, yeah, I mean, and again, important point on study designs and what you can extract from them. Last comment, Glenn?
Yeah, Glenn Hogberg, Norway, far away from here. Just a brief comment on the combo treatment. I think there are also cultural differences because we have been comparing our department with the Finnish, Tulikisaka. And in Finland, I don't know what kind of stomachs they have, but they managed to take all these pills, but in my department, we don't manage. We have less than 1% in the combination treatment. And I think we are more like the US. So I think there are cultural differences, but it is a good message, I think, also when you're looking at the prices and what you can afford. That is a huge message for those who can't afford it, that you can achieve a lot. Also looking at, for instance, the TCORA study, just by the DMARDs and the intra-articular injections.
All right. Well, thank you.